So I would like to discuss these topics as on the following headers. When to choose which component, either a packed red cell or a plasma, platelet or cryoprecipitate. And how often or when to check correlation parameters and interpretation of it. And when to consider thromboprophylaxis in an acute collapse. And a little bit on a massive transfusion protocol. So this slide essentially shows the blood components and its basic information. Fresh frozen plasma, it can be recovered from a whole blood donation, or you can apheresis the plasma, which will be a little more costlier. For a routine patient, it's not advisable. Each bag comes around a volume of 200 to 250 ml. Typical adult dose, you take it as a 15 ml per kg. So that you need to give around 3 to 4 bags. Then we can use something called a random donor platelets, which is a pooled platelet derived from a Buffy-Coat method or a platelet-rich plasma method that usually contains around 40 to 70 ml. So an adult dose is 1 bag per 10 kg. So in an approximate adult, you can use 4 to 6 bags in the time of crisis. Apheresis platelet, it's a platelet apheresis from a single donor. Usually volume around 250 to 300 ml. 1 bag is enough for an acute crisis event, which equates to a 6 bags of a random platelet, donor platelet. And the third thing is a cryoprecipitate, which is also prepared from a single donated water blood unit. It's separate from a FFP. That can be used, that's volume will be around 30 to 40 ml. So it's calculated 1 bag per 10 kg. I'll tell you how to choose it when you have different values of your fibrinogen level. Cryosupernatant is the product which remains in the FFP once you take a cryoprecipitate. It has use only in a limited setting in obstetrics when you suspect a thrombotic microangiopathy or a TTP-like situation, where you can give cryosupernatant like a dosage of FFP. Then comes a packed red cell. It's also, well, dosage is around 10 to 15 ml per kg. So definition, obstetric hemorrhage for a vaginal delivery more than 500 ml considered as a obstetric hemorrhage. For cesarean, 1 liter. Risk factors which is described are grand multiparity, prolonged induction, chorionitis, and multiple gestation abnormal placentation. So as Sachin previously showed, we how to roughly estimate the blood loss when they present to us. So when you have a class 3, class 4 hemorrhagic shock, you will have a tachypnea or respiratory rate 30 to 40 or more than that. Your output started coming down. Your pulse rate become a range of 120 or 140. And you know, this from class 3 and class 4, you need to add blood products along with crystalloids. Class 1, class you can manage with the crystalloids. Commonly described causes, as you all know, these are the commonly described causes of DIC in obstetrics. So how to do algorithmic approach? This is ISTH diagnosis scoring for over DIC. It's simple. You need to know a platelet count. It's given score more than 1 lakh 0, less than 1 lakh 1, less than 50,000 2. And almost all centers can easily do a D-dimer. So it's a normal cutoff is around 500. So in no increase, you give a score of 0. My moderate increase, like 500 to 1000, a moderate increase 2. Strong increase, take it as 3. You have to understand that pregnancy itself, it will be a little elevated. D-dimer will be there compared to normal population. Prothrombin time, you look into the, not look appropriately into the INR, look at the seconds it's increased from the baseline of your lab, normal range. So less than 3 second derangement, you score it as 0. If it is more than 3 seconds, but less than 6 seconds, score it as 1. More than 6 seconds, score it as 2. Fibrinogen level, as one of the speakers previously talked, general conventionally routine population we takes 150 mg or 1.5 gram as a cutoff, but in gynec obstetrics it should be taken as 200 mg. So if it is more than 1 gram per liter, consider 0, less than 1 as 1. So you score it. If it is more than 5, it's compatible with over DIC. and this you can use it to cycle on a day-to-day basis. So what component to be chosen for this? So practice point for general medical population, it should not be dictated on HB concentration alone. Should be added, you should need to look at the patient's clinical status. When indicated, you transfuse 1 unit and reassess. Most of the time, when in general medical population, this is not a crash. General medical population, you need to give and reassess. Most of the time, ask for 2 or 3 packed red cells. And hemoglobin of less than 7, it seems to be likely appropriate reduce mortality. 7 to 9 grams, it's not going to change anything in the mortality. And it's more than 9, if you transfuse, it's considered as unnecessary and usually inappropriate. Coming to platelet cryopreservation and FFP, more than 50,000 of platelet count is considered acceptable for vaginal or cesarean birth. However, lower platelet counts may be tolerated in case of a non-immune thrombocytopenia or immune-mediated distractions. Where to transfuse platelets? Risk benefit should be assessed based on the patients. Most of the time, if possible, get an expert assistance. Pre-existing hematology condition, we should have try to optimize it before this delivery, or a multidisciplinary plan should be there before pushing forward for the delivery. Coagulation parameter, what to be checked, how to use the results or interpret the results. We all know alteration, trophoblast integrity. This is tissue factor which in turn start the cascade. So coagulopathy, it's in this setting, it can be due to a dilutional coagulopathy, localized conceptive coagulopathy, a disseminated conceptive coagulopathy, or an increased fibrinolysis. So what values I suggest you to look at? It's easy doable except fibrinogen in almost all centers. Do a gas, look for the pH, base excess and lactate. Ionized calcium also comes in the same ABG report, and a platelet count and temperature and a INR and APTT. And a fibrinogen level should be there for a obstetric tertiary care setup. So in OBG settings, you should try to keep more than 200 mg. If it is less than 200 mg, we have clear data that it leads to progression of bleeding, increased requirement of red cells and other component requirement. And also there, it shows that it leads to the need for invasive procedures. So we should try to keep it more than 2 grams. And most of the time when we ask to monitor frequently, there's a tendency to keep pushing it to 24 hours or 48 hours. I don't think so it's appropriate in an acute care setting. Followed, once stabilized, these things can be managed, appropriately timed. PT APT ratio is more than 1.5 from the normal, it shows a hemostatic failure. Early unmonitored FFP administration, some people were previously talking, it can lead to transfusion associated circulatory overload and transfusion associated acute lung injury. I guess we should be very careful in these days where cases or issues happening over this maternal death or all sort of hospital deaths. There is no clear data supporting a fixed ratio. But as somebody previously suggested, 1:1 ratio RBC FFP is reasonable to prevent dilution coagulopathy. Point of care testing, as somebody was talking about, it's like a TEG or a ROTEM. It should be used as in a higher centers. It's easily available on rental basis. It gives a very good view of your active coagulation thing going on in front of your eyes if you use it in your high-end labor room or a OT. So I suggest you should try to incorporate in tertiary care centers of labor, like a PPH who manage. PPH ongoing, FFP 15 ml to be given. If you the ratio I previously described. platelet should be transfused when it dips rapidly less than 75 or it comes less than 50. That ratio also, it's no clear-cut guidelines. If you can put it on 1:1:1, it will be good. So again, just to relook into the previous thing, first slide I mentioned. So you choose components wisely, use it wisely. And in coming to critical bleeding and massive transfusion, increased volume of transfused red cells independently associated with the increased mortality. So don't pump just like that. Early transfusion of FFP and platelets associated with reduced mortality and subsequent reduced RBC requirements. Most of the time, order comes for 3 pack cells, 2 pack cells. Try to get this idea in the brain. You know, it's a crisis time, all will be on their toes. But, give some thoughts on this. A ratio of recommendation comes from Australian NBA is RBC-FFP ratio should be less than or equal to 2:1. This clearly showed reduced mortality from guideline from Australia and New Zealand. It's also, you see, it's grade D. And hypothermia, metabolic acidosis, thrombocytopenia, and coagulopathy may be independently associated with increased mortality. This is a talk on referral. I suggest referral in these kind of settings. You need to talk to your referral point side colleague, whether he will be able to give it in time. If not, I suggest you to optimize, try to optimize and send, or you will land up in bigger trouble. Okay. So I just wanted to touch on a point of care. It's a thromboelastogram. This gives a real-time assessment of viscoelastic clot strength. So what happens if you run it? It's reported over 45 to 1 hour. So, but as soon as you see it, see this initially it shows the clot formation and clot propagation and stabilization, clot dissolution. So you look at the timings. This gets stretched in a more and more. If it stretches, that means that your coagulation proteins are less. So this area is getting prolonged too much. You need more FFP. This angle and this amplitude, this is contributed by fibrinogen content and platelet content of your patient's blood. So this is getting more wide or smaller. Based on that, you can choose what you can give in real time. You don't need to send a sample PTA to your lab. It has to reach the lab. They have to put it in system. They have to report it. They have to just to get back. If you have a real-time thing in your lab, like most of the tertiary care have, you can see it your own. You can make the call. What should I do on this? These are various plots based on the hypocoagulable or fibrosis. I'm not going into detail. When to use thromboprophylaxis following acute collapse. Massive PPH coagulopathy, venous thromboprophylaxis should be started as soon as possible or once your bleeding is controlled. And ideally, it should continue for 10 days or until you feel there is some risk factors or it's already, it's no longer present. Massive transfusion protocol, as Dr. Sachin told, you need to evolve for your systems. I will show one from NBA I adopted. We have our own modification which we use in Rajagiri. So you need to put it such a way there's a critical bleed. You should define it. So massive hemorrhage that is life-threatening and likely to result in need for massive transfusion. So massive transfusion is defined as in adults, 1 blood volume in 4 hours or more, or of 1 blood volume in 24 hours. In maternity patients, massive transfusion can be defined as a transfusion of 5 or more units needed for next 4 hours. So we need to have a policy when implement this. This comes from a 3-point. You need a consultant in your site making the call. You need a call for it, like either a public system or you call up in your blood bank, and you need a carrier. This is a 3-point system which decides on it. So along with that, you need to send a baseline. If you don't have a point of care, you need to send a foot blood count, PTA, PTT, fibrinogen, biochemistry, and APG. Most of the time, they call for a massive transfusion protocol. They may not send it. Concurrently, you need to make sure this sample is taken and it send it to the lab. Then only we will able to go your second cycle. And I'm not going in detail of each and everything because it's already discussed in detail. And initial management, concurrently you identify the cause and compression, tourniquet, packing, and the dosages I already previously described. Tranexamic acid profound effect in this subset of patients. Yeah. Thank you.